Our bones are so much more than just a scaffold holding us up. They're like a living record, constantly writing and rewriting a story that's completely silent. So today, we're going to learn how to read it. We're going to uncover those hidden clues that can tell you the difference between a bone that's brittle versus one that's soft, and a simple fracture from something way more serious. And that question gets right to the heart of it, doesn't it? We hear these terms thrown around all the time. But here's the thing, they describe fundamentally different problems. So, what is actually going on inside our bones when things start to go wrong? All right, to get there, we first need to get a handle on the two most common culprits in adult bone disease. Now, they might seem similar on the surface, but trust me, they couldn't be more different. First up, osteoporosis. This is the one most of us have heard of, right? The best way to think about it is to picture your bone as a complex bridge. With osteoporosis, the internal steel support beams, the trabeculi, they start to thin out, almost like they're rusting away. There's literally just less bridge there. Now, while age is the main driver, stuff like long-term steroid use can really speed this up, making the whole structure incredibly fragile and brittle. Okay, now let's talk about its counterpart, osteomalacia. This isn't a problem of missing beams, it's a problem with the concrete. All the scaffolding is there, but the concrete, the mineral, never hardened properly. This is usually because of a lack of vitamin D. The result? You get a bridge that's soft, one that can actually bow and bend under weight. And that, right there, is the absolute crucial difference. Osteoporosis is about a loss of bone mass, which creates brittle bones that can snap just like a dry twig. Osteomalacia, on the other hand, is a failure to mineralize that bone, which results in soft bones that can bend. See, it's a totally different engineering failure, even if the outcome, fractures, is the same. So if these conditions can look so similar from the outside, how in the world do doctors tell them apart? And maybe more importantly, how do they figure out who's at risk in the first place? Let's take a look at the tools of the trade. For pretty much every patient, the investigation kicks off with a DEXA scan. It's a special kind of low-dose X-ray that very precisely measures your bone mineral density. This is really the gold standard for figuring out how much stuff is actually in your bones. So the DEXA scan gives you a number called a T-score. It's basically comparing your bone density to that of a healthy young adult. If your score is greater than -1, you're considered normal, you're in the clear. Now, if your score drops into this range between -1 and -2.5, you're in a category called osteopenia. Think of this as a yellow flag, a warning zone. It means your bone density is lower than it should be, but it's not quite low enough to be called full-blown osteoporosis. And finally, if your T-score is less than -2.5, that's it. That's the clinical definition of osteoporosis. At this point, the risk of a fracture becomes a very real, very serious concern. And this is the million-dollar question, right? That osteopenia range is huge, and not everyone who falls into it has the same level of risk. A T-score is just one number, after all. So how do you decide who actually needs to start treatment? Well, that's where the FRAX tool comes in. It's this really sophisticated calculator that goes way beyond just that one DEXA score. It pulls in a whole bunch of other clinical risk factors, your age, your sex, family history, lifestyle choices, and it uses all of that to give you a much more personal and accurate prediction, your specific probability of having a major fracture in the next 10 years. What FRAX really does is add crucial context to that number. It helps doctors zero in on who, within that huge osteopenia range, is actually at a high enough risk to make starting medication a good idea. It's all about personalizing the risk and moving beyond a single isolated number. But here's where it gets tricky. Low bone density doesn't always mean you have straightforward osteoporosis. Sometimes other conditions can actually masquerade as it, creating some really interesting diagnostic puzzles for doctors to solve. Two classic examples here are RSD and transient osteoporosis. RSD can trigger this intense, really localized bone loss after some kind of injury. And then there's transient osteoporosis, which is just bizarre. It's this condition that resolves on its own, often seen in the hip of pregnant women, where bone density just plummets and then mysteriously recovers all by itself after she gives birth. All right, now we get to the most critical part. When a bone actually does break, or is on the verge of it, radiologists basically have to become detectives. They are hunting for these subtle clues on the images to tell the difference between conditions that look eerily similar but need completely different treatments. So let's take a look at our first case. A patient comes in with bad hip pain. The MRI lights up with edema. That's just fluid in the bone. So what is it? Is this that temporary osteoporosis we were just talking about? Or is it something more sinister, like avascular necrosis, where the bone is actually dying? Or could it just be a simple stress fracture? And this is what's so fascinating. The entire diagnosis hinges on the shape of a dark line on that MRI. I'm not kidding. In transient osteoporosis, it's just a diffuse, blurry shadow. But in avascular necrosis, doctors are looking for a very specific squiggly or serpiginous line that's walling off the dead bone. And in an insufficiency fracture, that line is straight and it runs parallel to the bone surface. Tiny little visual details that make a world of difference in what happens next. Okay, let's raise the stakes even higher. An elderly patient comes in with a vertebral compression fracture. This is super common, but here's the critical, life-altering question. Did that bone collapse because it was brittle from osteoporosis, or was it weakened by a tumor? Again, it's the MRI that tells the story. A benign, osteoporotic fracture that usually shows up as a clean, sharp, band-like dark line. But a fracture caused by cancer often looks totally different. The signal is more blobby and diffuse, the whole vertebra might look abnormal, and, this is key, you might see other suspicious spots nearby. It is a distinction that changes everything for that patient.
Now, it's really easy to think of bone health as an issue that only affects us as we get older, but the story of our bones starts much, much earlier than that. To really get the full picture, we've got to widen our lens a bit.
These are called osteochondroses. They're conditions that affect the active growth plates in kids and teenagers. You've probably heard of Osgood-Schlatter, that painful bump below the knee you see in young athletes, but there are a bunch of others, like Sever's disease in the heel or Panner's disease in a young pitcher's elbow. All of these are just critical reminders that bone health is this dynamic, lifelong process that starts long before we ever even think about getting a DEXA scan. So after looking at all these different pieces of the puzzle, from density scores to these intricate fracture patterns, what's the big takeaway here? I mean, is it really as simple as just getting a DEXA scan and looking at your T-score? Is everything we need to know just hiding in the numbers? Well, the answer is clearly no. A number on a scan is just the first word in a very long sentence. Real insight, true understanding, it comes not just from measuring, but from seeing. It's about understanding the context, recognizing the patterns, and learning how to interpret the subtle, visual language that our own skeleton is speaking. It's all about reading the clues.